Thanks for joining us for another one of the series of physical examination for the orthopedic patient. I'm Neil Salyapongse. I'm one of the hand faculty here in the department, and I'm lucky this afternoon to have Dr. Jake Oman, who's one of our soon-to-be graduating chiefs, as our model patient. This afternoon, what we'd like to do is take you through a standard hand and upper extremity examination. So customarily, like most of the physical exam, we'll start with simple things like inspection. Jake, like most folks, has two arms, two sets of hands and wrists, so we can compare the two, the symptomatic and the asymptomatic side. So just looking at his arms, we don't see any gross asymmetries. Again, we're looking for color. Do the fingers look pink? After inspection, to make sure we don't see any gross deformities or asymmetries from side to side, we'll move on to range of motion for the elbows. So we think about range of motion in the elbows in two basic axes. The first is extension, so we have people straighten their arms all the way out. We term this 0 degrees because we're referring to the amount of flexion in the elbow. We then have people bring their elbows into full flexion, and this is typically somewhere between 140 to 150 degrees. So as long as that looks pretty similar, that's it for the flexion extension. We then move to second degree of motion, which is more of a forearm motion, but is an important part of the elbow as well. That is palms to the ceiling, which is supination, and palms to the floor, which is pronation. And that's usually about 70 to 80 degrees in each direction. Having done basic inspection, we would then, for the elbows at least, look at palpation to make certain that we feel the important structures and that they are not symptomatic. So, with the elbow slightly flexed, you can feel a bony prominence here out on the lateral side of the elbow. That's the lateral epicondyle, and might be a source of tenderness or pain if people have lateral epicondylitis. Using his other elbow here, on the inside, you'll feel a bony prominence. That's the medial epicondyle. You can also get epicondylitis in that area as well. Just posterior to the medial epicondyle, we have the ulnar nerve. That can be tender if people have any inflammation or neuritis of the nerve as it runs through the cubital tunnel. Again, we think lateral, medial, and then of course anterior and posterior for our definitions and when we're trying to communicate with one another. Another common condition that people present with is elbow pain, specifically lateral elbow pain. The most common diagnosis for that in the non-trauma setting is going to be lateral epicondylitis or tennis elbow. So what we'd want to do if we suspect that is palpate the lateral epicondyle, see if there's any tenderness. If there is, then move on to stressing the muscles that originate on the lateral epicondyle, which are predominantly the wrist extensors. So we'd have the patient straighten their elbow out, raise their wrist up, and then keep that pose while you have them resist attempt at forced flexion from that position. If that reproduces the pain in this area, that's fairly consistent with lateral epicondylitis, which is to be differentiated somewhat from an overlapping pain condition, which is tenderness about 6 centimeters distal to the lateral epicondyle over the wrist extensors again, which corresponds to the radial tunnel, a much less common site for radial nerve compression, but another one that can masquerade as tennis elbow. One last thing to test in the elbow, as it is a relatively common injury that we see, is the integrity of the distal biceps tendon. Now, in the shoulder series, you would have heard about problems with the biceps in the shoulder region, which can be an issue for rotator cuff problems. In the elbow, however, we think about the band right here is the distal biceps tendon. Now, if you bend against me, if you have someone flex against you, you can see A, the contour of the biceps muscle, and B, you can almost make out a little dip or divot here. And if you put your finger in there and pull, you can hook your finger on the biceps tendon and feel that it's intact. That test is important if you've had somebody who came in with anterior elbow pain after a resisted flexion injury. After inspection, one of the next tests is to check sensation. Part of the reason for doing that second is that if somebody's having pain, moving or stressing certain parts of the hand and wrist can make them reluctant to do anything else for you. If you start with something as simple as light touch, then you can build trust and find out some information about at least the integrity of the nerves. So when we think about the innervation of the hand, there are three major nerves that come down into the hand and wrist. They are the radial nerve, the median, and the ulnar nerves. Each has distinct areas that we test for sensory integrity, and we would do this with just gross light touch. So for the radial nerve, we would check the first web space dorsally, touching lightly and asking the patient if they can feel this. If they can, we would obviously compare the intensity of that touch to the contralateral hand, and if necessary, to other parts of the forearm or hand. The second spot we test is on the dorsal ulnar aspect of the hand, over the fifth metacarpal. This area is specific to the dorsal branch of the ulnar nerve and can help you differentiate between problems with the nerve at the wrist versus problems with the nerve at the elbow. We'd then have the patient fully supinate, check sensation in all of the fingertip pulps. Now, some of these are redundant because the thumb, index, and long finger, and typically half of the radial half of the ring finger, will all be innervated by the median nerve, whereas the small finger and the ulnar half of the ring finger will be innervated by the ulnar nerve. If you're doing a quick and dirty exam, what you'll want to do is test sensation in the index and the small finger, because those two are independent, with the index being median nerve innervated and the small finger being ulnar nerve innervated, with rare exceptions. After doing a sensory exam, we then move on to range of motion in the wrist and fingers. When thinking about range of motion in the hand and wrist, one of the motions crosses over directly with what we did at the elbow. That is pronation and supination. So again, we'll have the patient turn their palm toward their face for supination, which is checking motion at the distal radial ulnar joint, and then palm towards me for pronation. And again, the range of motion should mimic what you saw with the elbow earlier. The second arc of motion that we check is flexion of the wrist. So we'll have people bend as far down toward the palm as they can, and extension. And again, usually you're getting somewhere between 80, 85 degrees in each direction. Finally, back to neutral, we have radial deviation toward the thumb and ulnar deviation toward the pinky side of the hand. That constitutes the range of motion for the wrist. So when we think of the range of motion for the fingers, we think about combinations of flexion and extension mostly. So if we have the fingers relaxed and then go into full extension, we can see that getting to 0 degrees or even a little bit greater than that, little minus extension in the small and ring fingers at the metacarpal phalangeal joints, and full extension at the interphalangeal joints, full extension at the thumb interphalangeal joint. If we relax again, let the thumb drop down, and then focus on trying to bring the thumb back and up, the extensor pollicis longus tendon provides not only extension of the thumb at the interphalangeal joint and metacarpal phalangeal joint, but also allows for retropulsion, which is bringing the thumb away from the palm side of the hand up into the plane of the hand. When we then move to flexion motions, we would like to test joints that are moved specifically by different tendon groups. For the thumb, arc of motion that we're interested in describing is from the full retropulsed and extended position that we just saw to a palmally abducted and flexed position. The combination of palmar abduction and flexion allows us to oppose the thumb tip to the tips of the fingers. So when describing that particular motion, we're going to talk to people about palmar abduction and then flexion and opposition. For the fingers, we think specifically about flexion at each of the joints into a full fist, and then extension out again. Lastly, we think about abduction of the fingers, or spreading of the fingers, and adduction of the fingers. And people will typically be able to do that to varying degrees depending on their joint laxity. Another important part of the hand exam is being able to palpate areas of interest. Specifically, if we think about the palmar side of the hand and wrist, we have a few very prominent landmarks. If I can have you just bend against me, You might be able to see this a little bit, but you may not. With a patient flexing against resistance, you can feel across the palmar side of the wrist, and you'll feel three typically strong cords. The first longitudinal structure you feel radially is going to be the flexor carpi radialis tendon. The second is the palmaris tendon, which will be missing in roughly 20% of people. And then the third is the flexor carpi ulnaris tendon. Being able to identify those gives you some landmarks for the radial artery, which is just to the radial side of the flexor carpi radialis tendon. The ulnar artery, which you can typically palpate just radial to the flexor carpi ulnaris tendon. And if you follow the flexor carpi ulnaris tendon out, the small bony prominence you'll feel here is the pisiform. One final bony landmark on the palmar side, if you move in a diagonal direction from the pisiform toward the base of the index finger, in an adult, about 1.5 centimeters to 2 centimeters over, you'll feel another bony prominence, which is the hook of the hamate. While it's not common to have fractures of that bone, focal tenderness in that area may lead you to think about an injury, especially after a fall onto an outstretched hand. When palpating the dorsal side of the hand and wrist, we think about a couple of key landmarks. The first is just as you go proximal to the radiocarpal joint, a small bony prominence that feels about the size of a pea. That bony prominence is Lister's tubercle and is important for not only understanding where the extensor pollicis longus tendon may run, but also knowing that if people are tender just beyond that, they may have a possible injury to the scapholunate ligament, another common thing we see in falls onto outstretched hands. Moving ulnarly, we can find the space between the radius and the ulna as the distal radial ulnar joint. Tenderness can arise there for a number of reasons, including tendonitis, arthritis, or synovitis related to some inflammatory conditions. So palpating that area is helpful. Lastly, when palpating after an injury, especially fall onto an outstretched hand, we like to think about this anatomic snuff box. And if you can just extend your thumb up, we see that there are tendons that run here and here with a divot in the center. This divot is the anatomic snuff box, and it exists between the extensor pollicis longus tendon and the extensor pollicis brevis tendon. The APL is also over here as well, but we think of the snuff box as being between the two thumb extensors. Tenderness with palpation in that snuff box is often a sign of a scaphoid waist fracture. Manual motor testing is very important for understanding not only if tendons are intact, but also if the nerve function powering those tendons is working. From the dorsal side of the hand, we think about extension. So we'll extend the fingers, bring the thumb all the way into that retropulsed position, and then we have people hold that against resistance. So I'm going to push, don't let me. Good. Testing the retropulsion from the EPL. I'm going to push, don't let me. And if you press focally over the PIP joint or the proximal phalanx, you can see the extensor digitorum communis tendons pop up. And that's testing their integrity as well as the integrity of the nerve supply from the posterior interosseous nerve to those muscles. People do have independent extensors to the index and small finger, which you can test with having people do the hook 'em horns position or the I love you or rock and roll position, depending on whether you're Aussie fan or not. We'll then have people turn over and test flexion strength. So beginning radially, we'll brace the thumb and have them flex against resistance. And we grade the muscle testing similar to other parts of the body, with 5 out of 5 being normal, 0 being 0, and 3 being function against gravity. 4 is this big zone of everything in between 3 and normal. The second thing we test is the integrity of the tendons and strength of the tendons flexing the fingers. So the distalmost joint of each digit is flexed only by the flexor digitorum profundus tendon, which is a median or anterogyrosseous innervated muscle for the index and long finger, and an ulnar innervated muscle for the small and the ring fingers. So by having people flex against you and testing that strength, can you bend down hard for me? you can get a sense of whether those two terminal nerve branches are intact and the tendons are intact. The tendons being especially important if people have lacerations to the digits and you want to see if those tendons are still functioning. When testing the second flexor to the fingers, we want to focus in on the flexor digitorum superficialis, or FDS tendon. Now this is a little bit different because we need to take the flexor digitorum profundus tendon out of the mix. The way we do that is by extending the wrist, extending the fingers, and holding the fingers that we're not testing in full extension. We then ask the patient to flex just the finger we're interested in, so go ahead and bend as hard as you can. And you'll notice that while he bends at the metacarpophalangeal joint and the PIP joint, he's not able to flex at the distal interphalangeal joint. That's because the muscle belly to the profundus is one long muscle belly and shorter tendons overall. So when you hold 3 of the 4 fingers in full extension, suddenly the profundus to the middle finger, because it's tethered with these guys at length, cannot flex the middle finger any longer. If he can flex the middle finger with the other fingers extended, then we are looking at an intact flexor digitorum superficialis. And the same thing can be done for the ring finger or any of the digits. The small muscles in the hand derive their innervation either from the median nerve, which is mostly the thenar eminence muscles, or the ulnar nerve, which handles virtually all the other intrinsic muscles in the hand, or the small muscles of the hand. When testing for their integrity, the first thing we want to do is check for integrity of the recurrent branch of the median nerve to the thenar eminence. To do that, we have a patient palmarly abduct the thumb and then have them hold this position against resistance. If they can do that, then that nerve branch is intact. To test the ulnar innervated intrinsics, we focus on abduction and adduction of the fingers. So first, to see if they're simply there, we abduct the fingers, and then we adduct the fingers. And you can have them stress this against abduction or adduction. So we'll go ahead and abduct the fingers again, hold that position. I'm going to try to squeeze your fingers together. Don't let me. That ability to hold against resistance shows intact abductor digiti minimi, intact first dorsal interosseous, which brings the index over, and then the interossei in the hand that help with the adduction and abduction. The final set of small muscles in the hand we touched on briefly for range of motion earlier, but those are the lumbricals. And those are interesting muscles that begin on the flexor digitorum profundus and insert ultimately in the extensor apparatus through the lateral bands of the fingers. The unique posture for those is the platform. So we're going to go ahead and make a platform and then hold that pose. And you can test by pulling against the flexed MP and pressing down, trying to flex the interphalangeal joints. Another key component of the examination for common hand and upper extremity conditions is to test the nerves for possible compression. The most common nerve compression in the upper extremity is definitely carpal tunnel syndrome, followed closely by cubital tunnel syndrome. Carpal tunnel syndrome is compression of the median nerve as it passes through the tunnel at the level of the wrist. One of the most commonly employed tests for that is the Tinel sign. So what we do is we identify just an area just distal to the wrist crease and thump over that. If that reproduces the patient's symptoms of numbness, or if it results in a shocking sensation to the fingertips in the median nerve distribution, that's considered a positive sign. A second spot that we check is at the elbow. So again, finding that medial epicondyle, moving back behind it, and then tapping over the groove there will be a Tinel's maneuver on the ulnar nerve at the cubital tunnel. This time, however, instead of having symptoms reproduced in the median nerve distribution, you would expect symptoms to be produced in the ulnar nerve distribution. In addition to the Tinel's sign, we have a couple of compression tests. Beginning at the wrist, if we have the patient flex their elbow and then flex the hand down to 90 degrees, hold this pose for 30 seconds to a minute. If this results in reproduction of the numbness and tingling in the median distribution, this test, which is called Phelan's test, is considered positive. Related to Phelan's test is the flexion compression test at the wrist, also known by the eponym of Durkin's test. That involves application of a little bit of pressure directly where we tapped for the tenelles, and then slight flexion of the wrist. Again, you hold for about 30 seconds and see if that reproduces numbness and tingling in the median nerve distribution. Similarly, at the elbow, we can perform a flexion compression test, having that patient bend their elbow all the way up. We then find that medial epicondyle, go directly posterior to that, and apply pressure over the cubital tunnel or ulnar nerve. If this reproduces signs of numbness and tingling in the small and ring finger, then we would consider that positive. One final nerve spot that people check, since we don't want to leave the radial nerve out, is a point about 10 centimeters up from the radial styloid. So if you think about that's the snuff box of the wrist and move proximally slightly, you'll feel a bony prominence that's the radius. If you go about 8 to 10 centimeters up from that, along the radial side of the wrist, there is an area just above a muscle belly right here, which are the first compartment muscle bellies. And pressure in that area, if that is focally tender, that's Wartenberg's point and can be a site of compression for the radial nerve. Fairly uncommon, but completes the triad. Another common hand complaint is pain around the wrist, specifically the radial side of the wrist. Oftentimes this is atraumatic and develops over time. The pain people will typically localize is to this region right here, which is again near the snuff box between the first compartment tendons, i.e. the APL and EPB, and the EPL. If people have pain in this area, the first thing you want to check is tenderness. Do they have palpation tenderness directly over the first compartment tendons? If they do, that raises a strong suspicion for tendonitis of the first compartment, also known as radial styloid tenosynovitis, also known as de Quervain's tenosynovitis. To focally test for that, you can do Finkelstein's maneuver, which is to have the patient grasp the thumb and then tilt their palm or tilt their hand toward the table. If that reproduces pain here, then that's a positive test. A second thing that is a little bit more specific because of the fact that moving the thumb in that position can stress a lot of things in addition to the tendon, such as the joints or flexor tendons, is to do what's called a resisted hitchhiker maneuver. So you have the patient hitchhike the thumb up as high as they can get it, and then while supporting the metacarpal, you pull down on the proximal phalanx. So stay resisted up, I'm going to pull. By focusing in on just resisted extension at the metacarpal phalangeal joint, we're really coning down on that extensor pollicis brevis tendon, and that can be very specific for de Quervain's tenosynovitis. One very common problem that we see basically daily in the hand practice world are trigger fingers. People will come in complaining of difficulty extending the fingers after having flexed them into a full fist. If you suspect that that is what's going on, what you want to do is palpate the area where the trigger occurs, which is typically over the A1 pulley, or the first annular pulley in the hand. That pulley lives at the metacarpal phalangeal joint of the fingers, palmarly. One way to identify the location of the pulley is to find the distal palmar crease and the mid-palmar creases in the palm. Imagine a line connecting as much of those two as possible. The A1 pulley will live immediately distal to that imaginary line. So if, for example, I felt like Jake had a trigger of the middle finger, I would find that spot, palpate it, and see if it's tender. Then I would feel that pulley and ask him to make a fist as tight as possible, and then have him extend all the way out and see if I could feel a nodule move with that range of motion, or even potentially feel a click or catch as the nodule moves through the pulley and briefly gets stuck. For the thumb, you have a similar problem that can occur, and you're going to look for the proximal digital crease and just proximal to that for palpation. So that wraps it up for the hand and wrist examination. We threw in a little bit of elbow because it's connected. Thank you for taking the time to watch, and good luck with your examinations.